hear me now? I don't know if you can hear me.
Yes po, Dok. Okay po.
Can I start or we still need to wait for the others?
Dok, I think we can start already since it's already 10:20.
Kaya nga, it's 10 o'clock. Okay, I will share my... How do I? Wait. Switch camera. Share content. Screen. Wait for a while. Can you see my screen?
Yes po, Dok. Kita po.
I can eat. Not open. For the history, the Sumerians... For the history of wound healing, the Sumerians developed the first two modes of treatment, while the Egyptians described the infected versus non-infected patients. For the person, it is the Edwin Smith surgical papyrus 1650 BC who discovered the 48 different types of wounds. And Evers papyrus of 1550 BC discovered that honey, lint, and grease can uh, help hasten the or help make the wound healing faster. I should be doing this. The Greeks were the first to describe the difference between acute and chronic infection, while Galen of Pergamum noted that in moist environment, wound healing is faster. The word antiseptic was first noted by Eric Ignaz, Philip Simowitz, and Louis Pasteur in 1822 to 1895, wherein germs in and were always introduced from the environment. Joseph Lister developed the soaking solution phenol, and Robert Wood Johnson noted that antiseptic dressing can help also in wound healing. For the phases of wound healing, we have three phases of the wound healing. First is hemostasis or inflammation, followed by proliferation, and lastly by maturation and remodeling. So for hemostasis in inflammation, first, after disruption of tissue integrity or after the start of the wound, after you gained wound, there is blood vessel division, followed by extracellular matrix exposure to platelets, causing platelet aggregation, degranulation, and coagulation cascade activation in order to form the fibrin clot. And after the formation of the fibrin clot, starts the initiation of the wound healing. The fibrin clot is after the initiation of the fibrin clot, cellular infiltration is started with the predetermined sequence. First, they form polymorphonuclear cells or the neutrophils are the first to enter your wound site and they peak it around 24 to 48 hours. The function of your polymorphonuclear cells or your neutrophil is for bacterial and tissue debris phagocytosis, or they eat up the bacteria and tissue debris, and they are the major source of cytokines in early inflammation. This is initiated by TNF alpha because they form the angiogenesis and collagen synthesis. Then later, the PMNs release the proteases. So after the PMNs, the macrophages were the second to invade your wound. They peak at 48 to 96 hours post-injury and they remain until the wound is healed. The function of your macrophages is for your debridement of your wound, activation and recruitment of other cells by mediators, and regulate angiogenesis and matrix deposition and remodeling. This is followed after your first is your PMNs, followed by your macrophages, and next is your T lymphocyte. They usually peak about a week after your injury and they bridge transition to the proliferative phase of healing to your next phase. They downregulate effects of your fibroblast collagen so as not to overly overly initiate the growth factors, thereby causing your uh, this overgrowth of your wounds. Next in your phase is your proliferation. They start from days 4 to 12 and the reestablishment of the establish the restab, start the reestablishment of your tissue continuity. They are initiated by your fibroblasts and in your endothelial cells. With your proliferation, there are heritable disease of your connective tissue. They are consist of generalized, genetically determined primary disorders of one element of your connective tissue, mainly your collagen, your elastin, and your mucopolysaccharide. First of this problem is your Ehlers-Danlos syndrome, which is a group of 10 disorders that present as a defect in your collagen formation, encoding in the problem in the encoding of your alpha chains of your collagen type 5, and classic with phenotypic findings of a thin, friable skin with prominent veins, easy bruising or easy bruisability, poor wound healing, atrophic scar formation, recurrent hernias. Even if you repair them, you think that you repaired the hernias strongly, they still have recurrent hernias and they have hyperextensible joints. For the GI symptoms of your Ehlers-Danlos syndrome, they usually present with bleeding, hiatal hernia, intestinal diverticulae, and rectal prolapse. Others, they have small and large blood vessels are affected. Thereby, they usually present with bleeding. For the children, present for the children, they usually present with recurrent hernia and coagulopathy. The problem is they have platelet abnormality and low coagulation factors. Next is your Marfan syndrome. Usually, Marfan syndrome present with tall stature, arachnodactyly, lax ligaments, myopia, scoliosis, pectus excavatum, and aneurysm of ascending aorta. They have no delay in wound healing and they present with a defect in the mutation of FBN1 gene fibrillin. Next is your osteogenesis imperfecta. They present with brittle bones, osteopenia, low muscle mass, hernia, ligament, and joint laxity. The problem with your osteogenesis imperfecta is with limitation on your type 1 collagen and mutation on your prolodase. Patients with osteogenesis imperfecta usually present with dermal thinning and increased bruisability, but with normal scarring, and they have non-extensible skin, unlike your patients with with your Ehlers-Danlos and your Marfan's. Next is your epidermolysis bullosa. They have your epidermolysis bullosa present with four subtypes. These are EB simplex, junctional EB, dystrophic EB, and their Kindler syndrome. They show patients with your epidermis bullosa show impairment in tissue adhesions within the epidermis and basement membrane or dermis. The clinical factor is blistering and ulceration, or clinical they show blistering and ulceration. And this is a recessively inherited dystrophic type, and the defect is with your COL7A1 gene. Next is acrodermatitis enteropathica. This is an autosomal recessive disease of children, and usually they have the inability to absorb sufficient zinc from breast milk or food. The genetic defect is on their chromosome Q8Q24.3 noted on a SLC39A4 gene. They are characterized by impaired wound healing, erythematous pustular dermatitis of the extremities and the areas around body orifices. Diagnosis is by you examine the zinc level of your patient, and they usually show low blood zinc level, usually less 100 milligrams per deciliter. And treatment is by your zinc sulfate tablet, usually given at 100 to 48 milligrams per day. For your healing in specific tissues, we have your gastrointestinal healing. It begins with surgical and mechanical reapposition of the bowel ends. So, with the layers of your bowels, we have the epithelium, lamina propria, muscularis mucosa, then muscularis mucosa to your submucosa, then your serosa. Your submucosa is comprised of abundant collagen fiber, and it is the layer with the greatest tensile strength and suture holding capacity. So usually when we suture or anastomose your proximal and distal part of your colon or your ileum or your small intestine, we make sure that we include the submucosa. We always make sure that we suture the submucosal part of your intestine so as to make to be sure that the anastomosis is very strong. While your serosa is essential for achieving a watertight seal from the luminal side. Repair's early integrity is dependent on the formation of fibril seal on serosal side and the decrease in marginal strength on the first week. Early and marked collagenlysis is usually started by your collagenase, and it is and your collagenase is most marked at the colon than in the small bowel. Equilibrium between lysis and synthesis of your collagen is usually initiated by your collagen synthesis, started by your fibroblasts and smooth muscle. For the technical consideration for you to make sure that your repair has a tensile strength, it should be a tension-free repair. They have an adequate blood supply. You should make sure that your blood supply is not compromised. Adequate nutrition should be given to your patients. And if the patient is showing signs of sepsis, you should give them antibiotics. As for the technique, you should, as I've mentioned earlier, you should make sure that you should include your submucosa in your repair, not only your serosa. Or your submucosa should be included in your repair, not only your mucosa, to make sure that your repair is strong. And give adequate fluid resuscitation on your patient. When I say fluid resuscitation, the patient should not be overhydrated because it will make the bowels edematous, and the patient should not be also uh, uh, hypohydrate, should not be dehydrated, sorry. The patient should not be dehydrated because it will make the bowels also dry. With regards to your bone repair or for bone repair, and that is for your bone fractures, it is usually started by the accumulation of blood at the fracture site, followed by the liquefaction and degradation of non-viable products. Then this is followed by the bridging of fractured uh, bone segments or start of your soft callus, followed by the mineralization of your soft callus, converting it to bones. So if we see patients with bone fracture, what we do is we put post molds or circular casts so as to uh, make the bones before proximal and distal the area of fracture not move. Uh, Nakafix lang siya. We fix it by your long arm post mold or your circular cast. And we maintain the cast for 2 to 3 months because it usually takes us 2 to 3 months for the bones to heal. To finish the whole thing, the liquefaction and degradation and the formation of your soft callus. For cartilage repair, usually cartilages are avascular and depends on the fusion for transmittal of nutrients. Healing depends on the depth of your injury, and for superficial injury, they are usually slow to heal and often results in persistent structural defects. For deep injuries, they usually involve underlying bone and soft tissue, and usually cartilaginous defect starts healing by hemorrhage, followed by inflammatory response, and later on activation of your cellular function. For tendon repair, it is usually consists of your parallel bundles of collagen interspersed with spindle cells. The matrix is characterized by accumulation of your type 1 and type 3 collagen with increased water, DNA, and glycosaminoglycan contents. For their nerve defect or injury, they usually heal. For peripheral nerves, there is a complex arrangement of axons, non-neuronal cells, and extracellular elements. But for nerve injury, we have 4 types. We have neuropraxia, axonotmesis. We have 3 types. We have your neuropraxia, axonotmesis, and your neurotmesis. What is neuropraxia? Neuropraxia is focal demyelination of your nerve, while your axonotmesis is there is interruption of axonal continuity but preservation of your Schwann cell and basal lamina. We have your last is neurotmesis, which is the complete transection of your nerve. So usually with your neurotmesis, with the complete disruption of your nerve or the complete transection of your nerve, the muscle or the affected area doesn't have there is usually paralysis and paresthesia when you have nerve injury. The patient cannot move nor can he feel anything distal to the area of injury of your transection. There are 3 crucial steps in your repair of your nerve, we have the survival of your axonal bodies, regeneration of your axons that grow across the transected nerve to reach the distal stump, and lastly, migration and connection of regenerating nerve ends to the appropriate nerve end or organ targets. So, these three should be present with your nerve repair for you to have to make sure that your nerve repair is very strong. Sometimes the problem with your nerve repair is that since they are formed by your fibrins or your fibers, nerve fibers, it usually is very difficult to anastomose them. And you need a specific type of suture and specific type of suture technique to repair your nerve if you want to anastomose them again. We have your Wallerian degeneration, term as Wallerian degeneration. The proximal stump probes the distal stump and surrounding tissue. For your nerve wound healing, growth factors, cell adhesion molecules, and non-neuronal cells and receptor usually take part for your nerve wound healing. For fetal wound healing, usually they lack scar. The difference with your fetal wound healing with your adult wound healing is that they lack the scar formation part, and they have the transition wounds. Characteristics that influence difference between fetal and wound healing. First is the wound environment. Of course, the cells of the fetus is different from the adult patient, and inflammation. Usually, the inflammatory cells that go first are different from your from the fetal to your adult patients. The growth factors are also different, and the wound matrix that starts is usually also different. Now we have your acute classifications of wound. We have your acute and your chronic wound. For your acute wounds, you can usually have them repaired in three types. We have your primary closure, or what we call you suture the wounds at once. After debridement, you suture them to anastomose them. Second is your secondary intention, meaning you you have them debrided, remove the dirts and the infected wounds, then have the tissues grow by itself, just like in your abscesses. While your tertiary intention, the normal healing is constant with but non-continual, increase reaching the plateau. And the problem with tertiary intention is they have a delayed healing, thereby causing decreased wound breaking strength. So, patients usually managed by tertiary intention, the wound is easily bruised as well. Parang pag tinahi mo sila, even if you suture them back, once you put a pressure on the sutured wound, magse-separate ulit yung wound mo. That's the problem with your tertiary intention. What are the factors that causes delayed healing? First is your nutritional deficiency. Second is your infection. And third is your severe trauma. Usually, when these three are present, the healing of your wound is longer. For your impaired healing, it is failure to achieve mechanical strength equivalent to normal healed wounds. And another factor that causes delayed wound healing is their comorbids, meaning diabetes. Patients with diabetes, usually it takes longer for their wounds to heal. Second is your chronic steroid use. Usually those patients with dexamethasone, prednisone, and your dexamethasone usually uh, takes longer for the usual number of cells to go to the wound for them to make the wound healing faster. And next is radiotherapy. Factors affecting wound healing. First, advanced age. Of course, patients who are younger and old age, they usually take longer time for their wounds to heal. Patients with comorbidities, as I mentioned before, patients with diabetes, with hypertension, those with vascular compromise, though usually they have longer time for the wounds to heal. It takes longer time for their wounds to heal. Usually, it takes 1 to 9 days delayed. Kung hindi man sila delayed for 1 week, usually it takes longer. Another factor that affects wound healing, hypoxia, anemia, and hypoperfusion, vascular compromise in short, and significant impaired fibroplasia. There is also delayed wound healing for patients with decreased optimal collagen synthesis. Another factor is steroid and chemotherapeutic drugs, as I mentioned earlier as well. Patients also with reduced collagen synthesis and wound strength, usually they take longer time for the wounds to heal. Inhibit the inflammatory phase and release of your lysosomal enzymes. Medications that inhibit the inflammatory phase and release of your lysosomal enzyme, they usually take longer time for their wounds to heal. This is because of they inhibit epithelialization and contraction and contribute to wound infection. Wala patient yun, ulit? Wala patient yun? Okay. Contribute to wound infection. Chemotherapeutics agent hastens or prolongs wound healing by early cell proliferation and wound DNA and protein synthesis, causing extravasation. An extravasation causes tissue necrosis, marked ulceration, and protracted healing. For your metabolic disorders, patients with diabetes mellitus usually have prolonged wound healing because of the reduced inflammation, angiogenesis, and collagen synthesis. And patients with large and small vessel disease, usually they have prolonged wound healing because the vascular or the blood supply to the wound is compromised. Management for your diabetes mellitus, for them to have to make the shorter healing of wounds, correction of your blood sugar. You should correct your blood sugar to your until they have the normal blood sugar levels. Increasing inspired air tension, judicious use of your antibiotics, and correction of other comorbids or other problems. Patients also with uremia, decreased collagen synthesis, obesity, uncomplicated obesity, and have the prolonged wound healing as well. Uremia, why? Because they have decreased blood supply. Usually, uremic patients are usually anemic, meaning they have low red blood cell in their blood, thereby causing the vascular blood supply to the area of injury decrease. For visceral obesity, the problem is that they have a metabolic syndrome. The problem is their metabolism, thereby causing the injured wound to have prolonged wound healing. For the nutrition, poor nutritional intake and lack of individual nutrients also prolongs the wound healing. So for brief preoperative illness and nutrient intake in the period immediately after the operation. So usually when we operate on the patient and the patient is undernourished, we supplement them with IV food, IV parenteral nutrition, IV nutrition. We give them supplements by IV so as to make their wound healing faster. Okay? So that ends my lecture on wound healing. Any question? Any question?
No questions for them.
No questions. I will now I will now proceed with my lecture on sarcoma, soft tissue sarcoma. So for soft tissue sarcoma, sarcomas are a group of neoplasms that arise predominantly from cells of embryonic mesoderm. For the occurrence of sarcoma, 50 to 60% occur on the extremity, while 19% were noted on the trunk, 15% are noted on the retroperitoneum, and 9% are noted on your head and neck. For your anatomic site, usually the treatment and outcome of your sarcoma is affected by your anatomic site. The problem is, example, for your radiotherapy, because patients with sarcoma are usually managed with radiotherapy after their operations. With regards to retroperitoneal sarcoma, the problem is that you cannot just do your radiotherapy because it will affect your intestines. They might cause stenosis, or the lumen of your bowel becomes small. That's a problem. No problem with your extremity sarcoma because you can just treat them right at once with your radiotherapy. For your sarcoma, we have more than 50 subtypes in adult. The most common of your sarcoma is malignant fibrous histosarcoma, which is 20% diagnosis. Followed by your liposarcoma, wherein 15% of your sarcomas are noted, followed by your leiosarcoma, 12%, synovial sarcoma, 10%, and peripheral nerve sheath tumor, which is 6%. For your embryonal or alveolar rhabdomyosarcoma, it is the most common soft tissue sarcoma of childhood, while your pleomorphic rhabdomyosarcoma is the most common sarcoma in your adults. For your incidence in the US, they usually have 11,280 new cases every year. And for the deaths due to sarcoma, usually it is out of the 11,280, 3,900 deaths are noted every year. Uh, they usually affect 5 to 6 persons per 100,000 persons in 1 year. And for the occurrence, usually 1% of adult malignancy are usually sarcoma, while in children, usually sarcomas are noted 15% higher in children by 15. For their epidemiology, usually sarcomas are caused by your external radiation therapy. This is because of the mutation of their P53 gene and 8 to 59 times general population risk. Usually, patients with external radiation therapy have a secondary osteogenic sarcoma, MFH, angiosarcoma, and lymphangiosarcoma secondary to your exposure to your radiation. For the factors, it is usually dependent on the dose and the median time between radiation therapy or radiation exposure. For the other causes, occupational chemical exposure. Patients exposed to herbicides, to farmers. That is because of the phenoxy acid and phenols that is noted on your uh, herbicides. They are exposed to this, thereby causing mutations on your P53 gene as well. Chemical carcinogens like your toratras, vinyl chloride, and your arsenic, they usually also cause your sarcomas. So usually if we see patients and we are entertaining sarcomas, we ask them for their history as well as their job and what they usually use in their job, because usually they are exposed to these chemicals. And patients with chronic lymph edema, where do we see patients with chronic lymphedema? Example is for those with breast cancer patients. Usually, when we have patients with cancer patients of the breast, we do your modified radical mastectomy, wherein we resect most of the lymph nodes on your axilla. The problem with your massive lymphadenectomy on your axilla is that they cause your lymph edema. The affected site or your affected extremity usually becomes edematous and they enlarge for a long period of time, thereby exposing your patient to chronic lymph edema. And because of the chronic lymph edema, you can also cause your lymphangiosarcoma, thereby causing your lymphangiosarcoma. For your molecular pathogenesis, there are groups according to genetic development, usually specific translocation or gene amplification, osteogenic mutation, complex genomic rearrangements. For younger patients, sarcomas with identifiable molecular events usually are caused by your mutations and your translocations. And for older patients, sarcomas without identifiable genetic changes or expression, pleomorphic cytology. They exhibit pleomorphic cytology and their P53 dysfunction. For your translocation associated sarcoma, they have 14 subtypes and they present with 20 to 30% of all the sarcomas. They present with in-frame gene fusion and diffuse products usually affect the encoding oncoprotein. For the initial assessment of your patients with wherein you are considering sarcoma, clinical behavior is based on the anatomic location. So it depends on your if is the sarcoma located on your retroperitoneum, on your long bones or your muscle, or on your head and neck. The clinical behavior depends on the location of your sarcoma. Usually, your extremity sarcomas are metastasize faster than your retroperitoneum, but your the aggressiveness of the retroperitoneal sarcomas are more aggressive than your extremity sarcomas. And it also depends on your histologic type. The clinical behavior of your sarcoma is also dependent on the grade of the aggressiveness. Is it high grade or low grade? And the size of your and the size of your mass, the mass of your sarcoma. Usually, sarcomas is spread or metastasized by hematogenous sprouts, and this usually affects the lung. So the first organ that is affected by your metastasis is your lungs, and your lymph node metastasis is usually rare. For the clinical presentation, usually patients are asymptomatic. They just know that they have a mass, but they don't feel pain or they don't feel anything that is, they don't feel any pain on the areas affected. But they usually complain about is they have a mass. For tumors of their distal extremity, they usually are smaller, while your tumors of your proximal extremity and retroperitoneum, usually then when they present, they are already large. The tumor growth of your sarcoma is centrifugal, and for the differentials, you can either diagnose the patient as lymphoma, with lymphoma, lymphangioma, leiomyoma, primary metastatic carcinoma, melanoma, lymphoma, and neuroma. How would you differentiate them? By doing your biopsy. So you need to biopsy your mass in order to differentiate them or make the tissue diagnosis whether they are sarcoma really or just this benign conditions. For tumors less than 5 centimeter, which are new and not enlarging, you have the option to observe them. But for tumors more than 5 centimeter, which are enlarging and deep to the fascia, you should make a complete history, and you do your imaging, meaning you do your ultrasound, you do your x-rays, and lastly, you do the tissue diagnosis or your biopsy of your mass for you to make a definitive diagnosis of your mass. For the diagnostic imaging, the purpose of which is to define the size and anatomic location of a tumor and proximity to adjacent structures. It is also to stage the disease with respect to regional and metastatic spread and to guide your percutaneous biopsy. The purpose also of your diagnostic imaging is to establish if the tumor is benign or malignant, or it is low or high grade. For your radiographs, the purpose is to differentiate between primary bone tumors and your soft tissue sarcomas. But usually, radiographs are is best used for your bone tumors rather than soft tissue sarcomas. Usually, for soft tissue sarcomas of your extremity, we make use of your MRI to better see the characteristic of your mass. CT is also can be used, but it is useful in evaluation of your ureteroperitoneal, intra-abdominal, and truncal sarcomas. CT scan of your chest is for lung mets for patients is used for lung mets for patients with high grade tumors larger than 5 centimeter. And for your abdominal masses, and if you are entertaining your sarcomas, it is best to request your abdominal or pelvic CT scan. Your ultrasound can also be used to diagnose your sarcoma, the purpose of which is for patients with soft tissue sarcomas who cannot undergo an MRI. So, for patients who have previous fractures and they have a metal in their body, you cannot do MRI. So, instead of doing your MRI, you can request for your ultrasound. And they can also be used as an adjunct for indeterminate findings, MRI findings, and for delineating adjacent vascular structure. Your ultrasound can also be used as a post-op surveillance and to guide biopsies, meaning ultrasound-guided FNAB or ultrasound-guided core needle biopsy. For your computed tomography or your CT, they are for lung mets and presentation and before any radical treatment. For your evaluation and of your retroperitoneal sarcomas, and for your patients with myxoid liposarcoma, abdomen and pelvic CT is usually requested because subtypes metastasize to your abdomen. For your MRI or your magnetic resonance imaging, it is most useful for extremity sarcomas because of superior soft tissue contrast and multiplanar capability. They accurately delineate muscle groups, and they distinguish between bone, vascular structure, and tumor. They allow three-dimensional evaluation of anatomic compartments with its sagittal and coronal views. And for soft tissue sarcomas, usually magnetic resonance imaging or your MRI describes them as an heterogeneous mass when they see it on your MRI. The MRI is useful also for your assessment of tumor recurrence after surgery. Usually, we request MRI 3 months post excision or post radical resection to evaluate if there is a recurrence or not. Next is your PET scan or your positron imaging emission tomography. It is a functional imaging that measures the tumor uptake of the glucose analog FDG. They evaluate the whole body, not just a part of your body, but evaluate the whole body, and they assist in tumor grading and assess response to chemotherapy. They assess whether the chemotherapy is working on the patient or not. For the biopsy technique of your sarcomas, for your tissue diagnosis, we have the fine needle aspiration biopsy. This is an acceptable method when the result correlates closely with the clinical and radiologic findings. What do we mean by that? If you do an FNAB and the finding is usually negative, but you are with a high suspicion that the finding is sarcoma, you need to do their soft tissue biopsy again by doing your excision biopsy rather than just deciding with your fine needle biopsy result. It has a lower accuracy than core needle biopsy and often not sufficient to establish a specific diagnosis and grade. It is the procedure if choice to rule out the presence of metastatic foci or recurrence. Next is your core needle biopsy. Usually we make use of this instrument. These are how your core needle biopsy needles look like. They are safe, accurate, and economical. It is the preferred technique rather than your fine needle aspiration because they show 90%, 93% accuracy. The sample is usually sufficient for several diagnostic tests. Next is your incisional biopsy. They are recommended when core needle biopsy cannot produce adequate tissue or is non-diagnostic. The disadvantage, they need to be scheduled and general anesthesia usually is required and they cost higher than your compared with your core needle biopsy and your fine needle biopsy. For the possible complication of your incisional biopsy, hematoma, wound dehiscence, and tumor formation. The incision should be oriented longitudinally along the extremities. So, it should be pahaba yung incision nyo rather than cross-sectional. Next is your excisional biopsy. It is performed easily or unaccessible or superficial extremities or truncal lesions smaller than 3 cm. It should be performed on lesions on the hands and feet, and in patients with uncertain or unknown margins, re-excision is done to ensure negative margin with inclusion of your trocar site. So what is the difference between your incision and excision? Incision is you only take a part of the specimen or of the mass. You take only a small part of the mass and send it to the laboratory. Usually, we do incisions for specimens or for masses larger than 5 centimeter because it is very difficult to remove the whole mass. But for excisional biopsy, we remove the whole mass, meaning we remove the whole bulk of your tumor, the bulk of your tumor. We remove it completely and repair and suture it, close the wound, so as not to make remnant tissue on your mass on the affected area. For your pathologic assessment and classification, it is supported by ancillary technique, immunohistochemistry, molecular genetic testing for classifying subtypes, while your molecular diagnostic testing is used for your cytogenic analysis, fluorescent in situ hybridization, and your PCR. For tumors with limited metastatic potential, these are your desmoid, atypical lipomatous tumors, dermatofibroma protuberans, solitary fibrous tumor. Tumors with intermediate risk, these are your large myxoid component, while your highly aggressive tumors or highly aggressive sarcomas, these are angiosarcoma, clear cell sarcoma, pleomorphic and dedifferentiated liposarcoma, leiomyosarcoma, your rhabdomyosarcoma, NPNST, and your synovial sarcoma. The guidelines for the pathologic reporting of your sarcoma. First is your tissue primary diagnosis or your tissue diagnosis, followed by the anatomic site, which includes the depth, the size, and the histologic grade of your sarcoma. The presence or absence of your necrosis, or is there necrosis or none? The status of your excisional margins and lymph node, is there margin clear of your tumor or not? And your TNM stage. TNM stage for your tumor size, your the presence or absence of your nodal metastases, and M is for metastases on your organs, well, distal organs, your lungs, your liver, your brain, or on the abdomen. For the staging and prognostic factors, histologic grade of aggressiveness is the most important prognostic factor for your sarcoma. It is defined by your cellularity, differentiation, pleomorphism, necrosis, and number of mitosis per high power field. It is shown to predict MET's overall metastasis, overall survival, and overall survival. The grade classification system, we have we use three kinds of grading system. First is your NCCN or your National Cancer Center guidelines, which bases its staging by your histologic subtype, location, and amount of necrosis, or your FFCC, which stages your tumor by tumor differentiation, number of mitosis per high power field, and amount of necrosis. And next is if FFCC also differentiated by if is the tumor well differentiated, moderately differentiated, or poorly differentiated. For well differentiated, it is usually graded as 1. For moderately differentiated, it is graded by 2. And for poorly differentiated, it is graded as 3. For your tumor size and location, usually for T1 tumor, it is usually less than or equal to 5 centimeter. And for tumor grade 2, it is usually 5 centimeter or 4 or more. A lesions are tumors above the superficial investing fascia or extremity of the lung of the trunk, while your B tumors are tumors invading or deep to the fascia, and all retroperitoneal, mediastinal, and visceral tumors. For your nodal metastases, usually it is rare for sarcomas, and if they have a nodal metastasis, the possible diagnosis would be an epithelioid sarcoma, pediatric rhabdomyosarcoma, clear cell sarcoma, synovial sarcoma, and mysofibrosarcoma, and your last thing is your angiosarcoma. For your stage 4 to 3, usually it is based on the AGCC classification. For the clinical or radiologic regional lymph node metastases, if we find a lymph node on the inguinal area, we usually do FNAB on it and do a radical lymph adenectomy if it is positive for a tumor. For your distant metastases, the most common site for metastases is your lungs, followed by your bone, brain, and your liver. Visceral and retroperitoneal sarcoma, they have higher incidence of liver and retroperitoneal metastases. For the prognostic factor, the primary space, the prognosis is usually based on your primary tumor size. Is it big or is it small? Is it more than 5 centimeter or is it smaller than 5 centimeter? The grade, meaning is it well differentiated, moderately differentiated, or poorly differentiated, and the depth of your tumor. Does it include the muscle? Does it include only the peritube? Or does it include the bone? For the patient factor, is the patient old age or not? Is he younger or not? Or is he female or male? The microscopic margin and early recurrence after resection of extremity sarcoma, if there is presence of your recurrence at once after your resection, it is usually a bad sign, meaning there is decreased survival of your patient. For poor outcomes, usually patient with Ki-67 marker proliferation, E-cathedrin and catenin's proliferation, and high CD100 rate usually have poor outcomes. For the treatment of your extremity and trunk sarcoma, the goal is to maximize the likelihood of long-term recurrence-free survival while minimizing your morbidity and maximizing function. The recommendations, as noted on your table 36.3-3, the recommendation for the management of your soft tissue masses. Number one, soft tissue tumors that are enlarging or greater than 3 centimeter should be evaluated with your radiologic imaging, meaning your ultrasound, using your ultrasound or your CT or computed tomography, and a tissue diagnosis should be made using core needle biopsy. Once a sarcoma is diagnosis is established, we should obtain a imaging using your MRI or CT for other anatomic locations and evaluate for metastatic disease with chest CT for intermediate and high grade 1 or 2 or large for T2 tumors. A wide local excision with 1 to 2 centimeter margin is adequate therapy for low-grade lesions and T1 tumors, and radiation therapy plays a critical role in the management of large T2 intermediate and high-grade tumors. For radiation therapy, patients with locally advanced high-grade sarcomas or distant mets should be evaluated for chemotherapy. An aggressive surgical approach should be taken in the treatment of patients with isolated local recurrence or resectable metastases. For tumors, for tumors with no distant mets, surgery alone is suffice. But for tumors with unachievable pathologic margin or high grade, surgery plus radiation therapy is the management of choice. Factors affecting the surgical type, tumor location, tumor size, depth of invasion, involvement of nearby structures, need for skin grafting or autologous tissue reconstruction, and patient's performance structure. For your patients with sarcomas of your extremities, before we just cut off the affected limb, but now we are promulgating the limb sparing surgery so as to maintain the normal functioning of your patient. We just remove the tumor on the affected side. But the goal always the goal is to achieve a complete resection. No tumor should be left on site. Otherwise, if you deem that the tumor cannot be resected completely, you should better make a limb resection. You should remove the whole limb rather than spare the limb. Just so you can remove the whole mass. For microscopic or grossly positive resection margins, or those with a tumor recurrence or those with positive margins, you should do re-excision of the mass. For surgery, you can either do wide local excision. This is the preferred treatment for extremity sarcoma, or one of the ways to do a limb sparing procedure. The goal is to remove the tumor with 1 to 2 centimeter normal tissue. Dissection should proceed through grossly normal tissue planes, not abutting the tumor. For tumor near vessels, the adventitia or perineum should be removed. For tumors near bone or abutting bone, resection or remove the periosteum as well. But for tumors on distal extremity like your hands and feet, complete resection and reconstruction of the affected area. Then do your local regional lymphadenectomy for suspicious clinical and radiologically positive lymph nodes. But first and foremost, before you do your regional lymphadenectomy, do an FNAB or your fine needle aspiration on your affected lymph node. If you have a mass on your inguinal area, do a lymph node biopsy first before proceeding with your lymphadenectomy. But for tissues or masses which are very big and limb sparing surgery cannot be done, you should do your amputation. This is the treatment of choice for patients with recurrent or primary extremity tumors which cannot be grossly resected, with limb sparing procedures and preservation of function. For your isolated regional perfusion, a limb sparing technique of perfusing with high concentrations of tumor necrosis factor alpha and melphalan under hyperthermic conditions. The use of locally advanced, multifocal, locally recurrent, and usually are locally recurrent, and this is for palliative treatment to achieve a local control. They usually require isolating the main artery and vein from the systemic circulation, and chemotherapeutic agent is added and run for 90 minutes. For radiation therapy, part of the standard treatment for high-grade extremity and trunk wall sarcoma as on a neoadjuvant or adjuvant setting. What do we mean neoadjuvant radiation? Neoadjuvant is a radiation given prior to your operation, definitive surgery, where your adjuvant setting or adjuvant radiation is radiation given after you do or perform operation on the patient. For low-grade and superficial high-grade resected with adequate margin, they need no radiation. So for sarcomas, which are resected and blocked completely, with which are superficial or either low-grade, no need for radiation. For intermediate or high-grade tumors of any size, you need to perform radiation therapy after surgery. Usually, radiation is delivered using photons or particulate beams at 1.8 to 2 GY per day and 5 to 7 centimeter optional radiation margin. So from the area of incision or excision, at least extend 5 to 7 centimeter of your radiation to clearly burn out all the cancer cells around the initial site of your sarcoma. For your preoperative dose of your radiation or your neoadjuvant radiation treatment, it is usually given at 50 GY divided in 25 fractions, and you can do resection 4 to 8 weeks after the radiation. So you can do your operation 1 to 2 months after your last dose of your radiation. Reasons, because usually after radiation, they are adherent to each other and usually they are edematous. So you should make sure that the radiation effect on your tissue is decreased, meaning it is not already edematous prior to your operation, before you operate on the patient. Post-operative treatment is planned according to the tumor size, your grade, surgical margin, and institutional preference, and it should include the scar and drain site. It should also include placement of metal clips prior to the closure of your operative site. And usually post-operative treatment of your radiation is given at 60 to 70 GY. Another kind of your radiation therapy is brachytherapy. It involves placement of radioactive seeds through catheters inserted in the tumor resection bed. Advantage of your brachytherapy is shorter overall treatment time of 4 to 6 days, and it can be used for recurrent disease from previously treated with external beam radiation. For your preoperative radiation complications, first is your wound dehiscence, second is your wound necrosis, third is your persistent drainage, fourth is your infection, and last is your seroma formation, ulceration, and cellulitis. For your long-term complication of radiation or your chronic radiation treatment, these are fibrosis or contractures, lymphedema, neurologic injury, and last is osteitis and fractures. Variables associated with poorer functional outcome, these are higher doses of radiation, less than 63 more than 63 GY, longer radiation field, usually 35 centimeter, poor radiation technique, neural sacrifice, poor operative fractures, and wound complication. Systemic therapy. Standard chemotherapy is usually the following are the kinds of sarcoma that are chemosensitive. These are synovial sarcoma, myxoid or round cell liposarcoma, and uterine leiomyosarcoma. For sarcomas which are intermediately sensitive to your systemic therapy, these are pleomorphic sarcoma, mysofibrosarcoma, epithelioid sarcoma, leiomyosarcoma, and your angiosarcoma. While you are chemo-resistant or resistant to your systemic therapy, these are your clear cell sarcoma and endometrial stromal cell sarcoma. So meaning if you have a patient with clear cell sarcoma and endometrial stromal cell sarcoma, better not give them systemic therapy or your chemotherapy because it will not kill your cancer cells. But for chemosensitive and intermediate sensitive sarcomas, you can give your systemic therapy. What are the usual systemic therapy that is given? First is your doxorubicin, usually given at 75 milligram per meters cube every 3 weeks. These are given for advanced disease and usually given in 6 cycles. Next is ifosfamide at 9 to 10 grams per meter squared. This is the second line of treatment, but is the first line for treatment for patients with cardiac morbidity. For targeted therapy, usually we give your imatinib, which is a kind of tyrosine kinase inhibitor. And usually your imatinib is better given for patients with GIST or your gastrointestinal stromal tumor. For your neoadjuvant therapy or chemotherapy, as I mentioned before, neoadjuvant chemotherapy are therapies given before your operation. The rationale for use of your neoadjuvant therapy enables oncologists to identify patients whose disease is sensitive to a particular chemotherapeutic agent. It may shrink tumors, enabling less morbid operation. So pinapaliit nila, they decrease the size of your tumor, thereby making them operable. So for your post-treatment survival, this is recommended to our patients. Patients who have already undergone operation, chemotherapy, and radiation therapy should have every 3 to 6 months complete history PE and chest CT for 2 to 3 years after completion of their treatment, and imaging, either a CT scan of their abdomen and pelvis or MRI every year for 2 to 5 years. Management of recurrent and metastatic disease. As I mentioned earlier, the most common site of your metastasis is your lungs. We usually give doxorubicin for metastatic or recurrent disease. And for your isolated liver mets, you can either do a resection, meaning operation, or your radiofrequency ablation or your chemoembolization. For the particular sarcomas, first is your retroperitoneal sarcomas. This is the most of your retroperitoneal sarcomas are malignant. For the differential diagnosis, primary germ cell tumor, lymphoma, metastatic testicular cancers. They are usually two-thirds of them are high grade, and these are usually because of your liposarcomas and leiomyosarcomas. They usually present as large masses. 70% is more than 10 centimeter, usually present with more than 10 centimeter mass. For the symptoms, they usually present with early satiety and obstruction, abdominal obstruction. How do you diagnose them? By history and PA. And if you deem to do a laboratory, usually with the following are the ones requested. Increase LDH for patients with lymphoma, and for germ cell tumors, they usually have increased beta HCG and alpha fetoprotein. For the diagnosis, you can either do a contrast enhanced CT of the abdomen and pelvis, angiography or MRI arteriography and venography, and thoracic CT. For your tissue diagnosis, we usually make use of your CT-guided core needle biopsy for retroperitoneal sarcoma. You cannot do your blind shot core needle biopsy because you might affect or you might puncture the bowels instead of just the mass. For your treatment of retroperitoneal sarcoma, complete surgical resection. For the adjuvant therapy, radiation therapy for complex treatment with radiation therapy. Patients with high large tumors or recurrent tumors, they usually given 50 GY of your adjuvant chemotherapy first followed by surgical surgery or resection. Post-operative radiation is usually discouraged because they cause stenosis of your bowels. They burn your bowels, causing stenosis or small caliber of your diameter of your bowels. Treatment symptoms: early satiety and dyspepsia for upper GI tract patients with GI. Sorry. Next is your gastrointestinal sarcoma. Treatment symptom is early satiety and dyspepsia for upper GI tract, tenesmus, and changes in bowel habits for lower GI tumors. Diagnostics: usually patients will request for CT of the abdomen and pelvis, and endoscopy, either EGD or colonoscopy for patients with signs of obstruction and no lymphatic spread. For the treatment, tumor resection with 2 to 4 centimeter margin of normal tissue. Next of your sarcoma is your gastrointestinal stromal tumors or your GIS. They share phenotypic similarities with the interstitial cells of Cajal, and they express the hematopoietic progenitor cells or your CD34 and c-KIT or your CD117. The most common location of your GIS is your stomach, which is 60% of the time, and followed by your small intestine, wherein it is present in 30% of your small intestinal mass. Patients with gastric GIS has a more favorable prognosis or better prognosis. And for your diagnostics, usually we do endoscopy and or CT of the abdomen. For the metastasis, usually patients with GIS usually have liver mets and metastases on your abdominal cavity. For the management, for localized disease, we do complete surgical resection with negative margin. The, the 5-year survival of which is 20 to 44% of all patients with GIST and 75 patients with completely excised stage, early stage tumors. 20-month median survival for patients with metastatic disease. Locally advanced or metastatic disease, usually for those non-resectable, we give them imatinib mesylate or your Glivec. It is a selective inhibitor of your KIT protein tyrosine kinase. The problem with your imatinib or your Glivec is it is very pricey. One tablet costs about 45 to 50,000, and you give it 3 times a day, 3 to 4 times a day, depending on the size of your mass. So you are about to spend 150 to 250,000 per day for patients with GIST if you deem them you wanted to give them imatinib rather than do operation. Next is dermatofibroma protuberans. It is a rare low grade sarcoma arising in the dermis. It rarely metastasize but are aggressive, and the location usually it is on the trunk, head and neck, and extremity. And they present as a nodular cutaneous mass that grows slowly and persistently. They arise from chromosomal translocation of your 17 and 22, and treatment is your imatinib. For pediatric tumors, they are relatively rare, occurring in 7 to 8% of all pediatric cancers. We have the two groups of sarcomas which are noted on your pediatric population. These are rhabdomyosarcoma and the non-rhabdomyosarcoma group. For the rhabdomyosarcoma group, it is the most common kind of sarcoma among children younger than 15 years old. It can occur at any site comprised of striated muscle. The presentation is usually a painlessly enlarging mass, and depending on the location, usually in the gut, it presents. Usually for the gut, it is present in 24%. Extremity is 20%. 20% for your head and neck, 16% for your parameningeal region, and 22% for other sites. For your small round cell tumor, the demonstrating differentiation on light microscopy and immunohistochemistry. For extent of the disease, strongest predictor is of long-term outcome. So if the sarcoma is very big, it means means a poorer prognosis for the patient. For the treatment, complete surgical resection, and they have a higher incidence of lymph node metastases. If they have an distal organ metastases, they usually affect the lungs, followed by the bone and the bone marrow and the bone. For the non-rhabdomyosarcoma group, we have 4 groups. First is the fibrosarcoma. Next is your Kaposi's sarcoma. Then followed by your other specified soft tissue sarcoma. And lastly is your unspecified soft tissue sarcoma. Treatment and diagnosis is by history and PE, and by imaging, by MRI or CT scan of the chest. Treatment is surgery. And lastly is melanoma. Primary arises from melanocytes at the epidermal junction that have undergone dysplastic changes. They also occur in mucosal surface of oropharynx, nasopharynx, eyes, proximal esophagus, anorectum, and female genitalia. Risk factors for having melanoma. First is exposure to solar UV radiation. Are those always on your tanning bed? More than 10 times tanning bed sessions, they increase the possibility of having your melanoma twofold. For the first personal history of melanoma, tenfold increased risk. For dysplastic nevus syndrome, 100% lifetime risk. And for your giant congenital nevi, 5 to 8% lifetime risk. For the pathogenesis or your melanoma, they usually start as a localized radial growth phase followed by a vertical growth phase. For the subtypes of your melanoma, we have your lentigo maligna, superficial spreading, acral lentigus, mucosal and your nodular, followed by your polyploid, desmoplastic, amelanotic, and soft tissue. For your lentigo maligna, it is usually found in older and located in the head and neck region. For your superficial spreading, they are usually found anywhere in the body except in the hands and feet, and it is usually the most common type of your melanoma, occurring in 70% of patients. Next is your acrolinthigus, which is a 29 to 79% of present in dark-skinned individuals, noted in the palmar, plantar, and subungual surfaces, followed by your mucosal and your nodular. Your nodular, usually they present in 15 to 30% of all your melanomas, and they begin with a vertical growth phase. They have the worst prognosis of all your melanomas. Most common manifestation, asymmetrical outline. We have your A, B, C, D, E of your manifestation of your melanoma. A for asymmetric outline, B for changing irregular borders, C for color variations, D for diameter bigger than 6 millimeter, and E is for elevation. Usually, they present as pigmented lesions that has enlarged, oscillated, or bled. For the diagnosis and staging, as for all other sarcomas, history and physical examination is very important. And for suspicious lesions, you should do an excision biopsy with 1 to 2 centimeter margin. And specimens should be full thickness of the lesion and a small lesion and a small section of normal adjacent tissue should be included. For your suspicious lymph nodes or your lymph nodes which are enlarged, you should do FNAB of the suspiciously enlarged lymph nodes. Then if it is positive for your melanoma, do a lymphadenectomy. Prognostic indicator of your survival, overall tumor thickness, ulceration, and mitotic rate. For your determinants of prognosis, or is the patient going to live longer, or the recurrence rate is higher or not, it is based on the number of positive nodes, the tumor thickness, the mitotic rate of your melanoma, the ulceration of your primary tumor, and the age of the patient. And usually with patients with melanoma, we request for lactate dehydrogenase or your LDH. And if it is elevated, it presents as the worst prognosis. For the treatment, we do excision for patients with 1 millimeter, less than 1 millimeter mass. We do excision of the mass together 1 centimeter margin. For 1 to 2 millimeter mass, we do an excision with 1 to 2 centimeter margin. For 2 to 4 millimeter mass, we do 2 centimeter margin. And for more than 4 millimeter mass, we should do a resection of the primary tumor with 2 centimeter margin. Individuals with face, anterior scalp, and ear primaries with positive lymph node do superficial parotidectomy and radical lymph node dissection. For lungs and the lungs and the liver are the most common site of your metastasis of your melanoma, and adjuvant and palliative treatment of your melanoma, patients are usually given high dose interferon alpha. So that ends my lecture for your sarcoma, melanoma, and wound healing. Any questions? My lecture is taken on the Swartz, so I will not give you my I don't know if you record it or not, but the book, it's from your Swartz, okay?
Okay po,
I
Doc.
will my screen share. Any questions? Your exam will be next week, I think. Is it next week?
Next week po, Doc.
Okay. Then I don't know how many items I will give. I will ask Doctor Primando first how many items. Okay?
Okay po, Doc.
Okay. So any more questions? None. No questions?
I think no more questions from the class po.
Okay, then that ends my lecture for this part of your uh, class. Okay? See you on your exam.
Thank you po, Doc.
Good luck on your exams. Bye-bye. So you can rest for your next lecture. Bye.